Greetings. Let us review the anatomy of the colon with a special reference to endoscopic mucosal resection and endoscopic submucosal dissection. This is a view of the colon, and when you look into the details of the wall structure, as you go from the lumen, the first layer is the mucosa, then submucosa, followed by muscularis propria, and finally the outermost layer is called the serosa. Here you see pericolonic vasculature and lymph nodes. Let us look at the details of the mucosa. Mucosa has epithelium that lays over lamina propria, and the muscularis mucosa separates the mucosa from the submucosa. So with this understanding of the layers of the colon wall, let us look at colorectal neoplasia as it evolves. As you can see here, this is a tumor that is actually going down into the lamina propria, touching the muscularis mucosa, penetrating the muscularis mucosa, extending deeper and deeper into the submucosa, and finally invading the muscularis propria. So let's figure out what all these extensions mean. If the tumor is limited to the epithelium, that is, it is not invasive, intraepithelial neoplasia, depending upon the differentiation, it could be low-grade or high-grade dysplasia. When the tumor invades into the lamina propria and extends up to the muscularis mucosa, it is called intramucosal cancer or carcinoma in situ. When the cancer penetrates the muscularis mucosa, it is invasive submucosal cancer, SM1, SM2, or SM3, depending upon how deep the cancer extends into the submucosa, whether it is limited to the upper one-third, middle one-third, or going into the lower one-third as well. When the cancer penetrates into the muscle or muscularis propria, it is called a T2 cancer. So this nomenclature is very important for management of patients with either any form of early neoplasia or colorectal neoplasia. When it comes to colon, lesions that are limited to the epithelium or high-grade dysplasia or low-grade dysplasia can be resected with a curative resection. Lesions that are limited to the mucosa, that is intramucosal cancer, can also be treated with a curative resection. But when the cancer extends into the submucosa, then it depends upon how far deep it extends in terms of the lymphatic involvement. Unlike esophagus and stomach, colon has sparse lymphatics in the upper one-third of the submucosa. So that gives us a little more room for curative resection in the colon with either endoscopic mucosal resection or endoscopic submucosal dissection. Let's look at the lymph node involvement depending upon the depth of penetration of the cancer into the submucosa. SM1, the risk of nodal invasion is about less than 1%. So if the cancer is less than 1000 micrometers from the muscularis mucosa and it is well differentiated and there is no lymphatic or vascular invasion, you could pretty much say that you achieved curative resection. When the cancer goes into the SM2 phase, there is a 6% nodal invasion, and when it goes deeper to SM3, there is a 14% nodal invasion. So I hope this brief overview of the stages of evolution of early colorectal neoplasia is useful. Thank you.